So this is a brief and rapid revision. Anemia. What is anemia? Decreased hemoglobin with respect to gender, age, and physiological status. For example, in pregnancy and lactation, there can be decreased hemoglobin, but still we do not label it as anemia. As the hemoglobin decreases, the oxygen carrying capacity of the blood also decreases, which produces signs and symptoms with which the patient is going to present. Diagnostic cutoff values are in males less than 13 gram per deciliter and in females 12 gram per deciliter. If less than that, we will label it as anemia. We have to consider the age, gender, and physiological status when interpreting the values. Symptoms. First symptom will be weakness and fatigability due to inadequate tissue oxygenation. Second, there will be palpitations or can be palpitations. It is because due to compensatory mechanism the cardiac output increases. So the heart rate increases to meet the oxygen demand of the body tissues. That's why the patient feels palpitations. And exertional dyspnea, as the patient exerts, for example during exercise, all already there is less oxygen perfusion to the tissues, so ultimately lungs are going to increase work, meaning hyperventilation going to start, and because lungs cannot compensate fully for oxygen, and that's why exertional dyspnea patient may feel dyspneic or shortness of breath. What are the signs? There will be pallor of the palms, nails, and palpebral conjunctiva. Compensatory mechanism in anemia. One is cardiovascular. There is increased heart rate, increased stroke volume, which leads to increased cardiac output. But there is one complication related to this, that it can cause high output cardiac failure. Number two, oxygen transport, rightward shift of oxygen hemoglobin dissociation curve. When it shifts to the right, the affinity of hemoglobin for oxygen decreases, and so that the more delivery of oxygen to the tissues. And number third is volume regulation. There is expansion of the plasma volume. As the plasma volume expands, it is actually the body trying to compensate that. If the by increasing the plasma volume, maybe it can compensate the tissue perfusion, yeah, tissue oxygenation. Reticulocyte count. Reticulocyte immature RBCs released from the bone marrow into circulation. Reticulocytes are the immature RBCs released from the bone marrow into circulation, and in the circulation they are converted into the mature RBCs. They contain residual RNA, and that's give them a bluish coloration. If the retic count is increased, for example, meaning it is greater than 2%, it suggests blood loss or hemolysis. There are only two causes where retic count is increased. It is either blood loss or it is either hemolysis. If the retic count is decreased, meaning less than 2%, it represents the three things. These are three things are inadequate marrow response due to three conditions. First, there is decreased erythropoietin. For example, in CKD, there is decreased erythropoietin, so bone marrow is not being stimulated, and so the retic count is less. Deficiency of raw material. For example, iron, vitamin B12, and folic acid are required for synthesis of blood cells. So if the deficiency of there is deficiency of raw material, bone marrow cannot synthesize new cell, and the retic count will decrease. And number three, there can be disease of bone marrow. For example, in aplastic anemia, marrow replaced by fat. In myelofibrosis, the marrow is replaced by fibrosis. And in tumor infiltration, which is called myelodysplasia, meaning abnormal cells are infiltrating the bone marrow. In all above cases, the retic count will decrease. RBC indices, the two most important are mean cell volume and MCH, mean corpuscular hemoglobin. Mean MCH is the average RBC volume. Normal size is 80 to 100 femtoliter. Classification by MCV: if less than 80 femtoliter, then it is microcytic. If 80 to 100, it is normocytic, and if greater than 100, then it is macrocytic. MCH is the average hemoglobin content per RBC. Normal is 28 for 34 picogram, and based on this we can also classify the anemia. Increased, if the hemoglobin is increased, it is called hyperchromic. If normal, normochromic, and if it is decreased, it is called hypochromic. But the first one is very rare, like hyperchromic is rare, but it can occur, for example, in maybe in polycythemia. So moving on. So now combining both MCV and MCH, we can classify anemia like microcytic hypochromic anemia, normocytic normochromic anemia, and macrocytic normochromic anemia. Other patterns are possible, but these are just for an example that how we can classify them. What a patient of with these symptoms is going to present to us, what are the, if we're suspecting anemia, what is the workup that we need to do. So initial investigation includes CBC. First we check hemoglobin, TLC and platelets, because if lone hemoglobin is decreased, then it is anemia, and if the TLC and platelet are also decreased, then it means it is pancytopenia and it has other causes. First of all, if there is pancytopenia, there can be bone marrow problem like myelofibrosis, aplastic anemia, or myelodysplasia as discussed earlier. There can be deficiency of raw materials for folic acid and vitamin B12, both of them. Not iron, because iron deficiency of iron only affects hemoglobin or RBCs and causes anemia. But if these two are deficient, then there will be pancytopenia. And hypersplenism, because hypersplenism causes destruction of all three cell lines. So when we get CBC, we check hemoglobin. If it is decreased, then anemia is present. Then we also check TLC and platelet. If both of them are also decreased, then the problem is above as listed. It can be it is pancytopenia, either due to bone marrow problem or deficiency of folic acid or B12 or hypersplenism. Number 2 is we are going to look at MCV, which give us a clue. It is either microcytic, normocytic or macrocytic anemia. And number 3, we are going to look at the reticulocyte count. If it is less than 2, then there is problem with the bone marrow, and if it is greater than 2%, then the cause is either hemolysis or blood loss. And number 4th investigation is peripheral blood smear. We assess the RBC morphology to support diagnosis. So there are basically two main investigations, and we are getting whole of this information like CBC and peripheral blood smear. Only two investigation will give us a lot of information regarding anemia. Now we are going to discuss specifically microcytic anemia. In microcytic anemia, hemoglobin will be decreased and MCV will be less than 80 femtoliter. On CBC there will be decreased hemoglobin, but TLC and platelets usually normal. Reticulocyte count varies by cause. For example, if there is iron deficiency or if there is blood loss or hemolysis, it will depend upon that. And peripheral smear will show microcytes and microcytosis and hypochromia. What is the pathophysiology behind this decreased hemoglobin? We know hemoglobin has two parts. One is globin chains and other is heme. If the defect is with the hemoglobin chains, then it will cause thalassemia. But if there is problem with the heme, then it can be iron deficiency anemia because no iron for heme synthesis. It can be anemia of chronic disease because iron is there but it is trapped and unavailable for synthesis of heme. Or it can be sideroblastic anemia, impaired heme production despite adequate iron. And we will study the causes of sideroblastic anemia later on. Okay, why there's impaired heme production. Now we are going to discuss iron deficiency anemia specifically, and it is the most common anemia worldwide, and it is the most common nutritional disorder globally. Some information on iron metabolism or sources of iron: plant-based or leafy green vegetable. Iron is in oxidized form, meaning Fe3 plus form, and animal-based red meat. It is rich in iron, and iron in it is in reduced form. So in the body only reduced form is absorbed from the GIT. So first, if there is oxidized form, it needs to be converted to reduced form. So gastric acid and vitamin C converts oxidized oxygen to reduced form, so making it absorbable. And iron is absorbed in the duodenum. If there is problem in the duodenum, iron will not be absorbed. For example, in celiac disease, the duodenum is affected and impair iron absorption. Distribution in the body: about 80% iron is used in hemoglobin synthesis, remaining 20% in the synthesis of myoglobin and other iron containing enzymes. Iron is stored in ferritin, and it is stored in the reduced form. Iron stored in transport: only reduced ferrin can bind to transferrin, and only reduced form can bind to hemoglobin. Only reduced form can bind to oxygen. So transferrin transports reduced iron in the blood, which is Fe2 plus, and ferritin store protein storage. Ferritin is storage protein for iron, and iron in it is also stored in the reduced form. So that's why the reduced form is important. As we discussed, like if there is problem with the gastric acid production, for example gastrectomy, or if there is there is no deficiency of vitamin C, then iron is not going to be absorbed in the GIT, or either it is problem with the duodenum, then it is also not going to be absorbed. Now we will see what is the ferritin diagnostic importance in the microcytic anemia. So it is a most accurate and most useful test for iron status. Normal range is 20 to 300 nanogram per ml. If it is less than 10 nanogram per ml, then there is iron deficiency, and if it is greater than 500 nanogram per ml, then there is hemochromatosis, which means there is iron overload. But we have to note one thing, that ferritin is also a acute phase reactant. So if there is inflammation or acute inflammation in the body or infection, it will be raised, but it doesn't mean the patient can have iron deficiency anemia. But in this case, the ferritin will be can be normal. So we have to look at the patient is not suffering from any kind of inflammation or infection. Now, what are the causes of iron deficiency anemia? First of all, dietary deficiency or increased demand. For example, in children there is increased demand. In elderly patient, there is dietary deficiency. In pregnant and lactating women, there is increased demand of the uh, uh, iron. Number two is malabsorption. If there is celiac disease, it affects duodenum and iron will not be absorbed. Similarly, if there is a gastrectomy, the loss of gastric acid impairs the conversion of oxidized form to reduced form, so iron will not be absorbed and it will lead to iron deficiency. Number three, blood loss. In this case, the reticulocyte count will be greater than 2%. For a woman less than 50 years, heavy menstrual bleeding is the most important cause of iron deficiency and iron deficiency anemia. And in women and men greater than 50 years of age, colorectal carcinoma is the most important cause until proven otherwise. Other causes include peptic ulcer disease. For example, there will be slow loss of blood, gradual inflammatory bowel disease presents with the bloody diarrhea and loss of blood. Angiodysplasia, there will be small abnormal vessels in the gastrointestinal tract that will leak blood and it will cause blood loss. Similarly, if there is hookworm infestation, it also sucks the blood, so there will be iron deficiency. What is the clinical presentation? As we discussed earlier, there will be general fatigue, low energy, exertion, dyspnea, and palpitation. Specific signs are chylonychia, which are spoon-shaped nails, angular cheilitis, inflammation at the mouth corners, and pica is a craving for non-food substances for clay, and Plummer-Vinson syndrome. Patient can present with Plummer-Vinson syndrome. It is iron deficiency anemia plus esophageal webs. The patient will be presenting with the dysphagia and beefy red tongue, which will be seen on examination. So now, if we are suspecting iron deficiency anemia, if on CBC there is iron deficiency anemia, how are we are going to do workup for this? First diagnostic workup with number one step is we have to get our CBC. The findings will be decreased hemoglobin, decreased MCV, platelets may be normal or they can be increased, but in this case TLC count will be normal. Then we are going to get iron profile. In iron profile, it includes serum iron, but serum iron is less reliable marker. So the most important is serum ferritin. It will be decreased in case of iron deficiency anemia. It will be less than 10 nanogram per ml, but it is not 100% sure that it will be less than 10. It can be below at the lower borderline or normal limit. Then there is transferrin saturation. It will be less than 20%. It will be decreased, and there is total iron binding capacity, which is reflected by it is the only condition where the TIBC is increased. Iron deficiency anemia is only condition where TIBC is increased. It is actually the binding of iron to the transferrin. So we see how much transferrin is saturated, and from that we calculate total iron binding capacity. And it is only because body senses that there is deficiency of iron, and it is trying to increase the transferrin so that more and more uh, iron can be transported, so that's why it will increase. Normal total iron binding capacity is 240 to 450 microgram per deciliter. We also, the history in this case is very important. We can reverse the order. First we get history, then CBC and iron profile. Of course, check is there adequate intake, malabsorption. For example, if there is chronic diarrhea which can represent celiac disease, or infant feeding, the breast milk is low in iron and vitamin D, so we have to check this. If there is any blood loss, for example, if it is a young woman, heavy menstrual bleeding can be a cause. Ask about if there is melena or GIT bleed and any other chronic blood loss. Patient may have noticed blood loss. And number fourth is we get a stool for occult blood if we cannot find obvious loss of blood, and if it comes positive, then we proceed with endoscopy and colonoscopy to rule out the GI bleed and malignancy. And number 5 is the peripheral blood smear, and it will show microcytic hyperchromic RBCs and with central pallor. So investigation, first we are going to get history, and then we are going to get CBC, iron profile, stool for occult blood if there's no obvious history for blood loss, and then we can and then we will get peripheral smear, blood smear, but it is optional if the that because it is just for the confirmation to check whether there is a bone marrow cause. It can be a bone marrow cause, so it is optional, but first three investigations, they are mostly done. Now we are going to discuss the treatment. First of all, we have to treat the underlying cause, because without treating underlying cause we are not going to improve the iron in the body. So treating after treating the cause, then we can give iron supplementation, which include ferrous sulfate, ferrous gluconate, and ferrous fumarate. Duration is 3 to 6 months. After 6 months, and in that duration the HB normalizes. We can also give IV iron, and the indication include iron. Oral iron is not tolerated. For example, patient is suffering from celiac disease. If we give him orally, there will be no absorption. So, and if there is malabsorption, as said earlier, and need rapid correction, for example in pregnant ladies, we need to restore iron rapidly, so we have to give IV iron. Preparation include iron sucrose, which comes in the brand name of Venofer, and iron carboxymaltose, which comes in the name of Frinject. And we can do blood transfusion if the hemoglobin is less than 7 gram per deciliter, but normally if the patient is stable, and even if the hemoglobin is less than 7 gram per deciliter, we usually go with the oral iron supplementation. And if the urgent correction needed, for example pregnant woman with severe anemia, then we have to give a transfusion. For example, if she is undergoing birth childbirth, then we obviously have to give blood transfusion. Now, how the monitoring is done. CBC every 2 to 4 weeks. Hemoglobin increases by 1 gram per deciliter in almost 4 weeks. If it is increases by 1 gram per deciliter in 4 weeks, then it is a good response. We also check reticulocyte count, which was low in iron deficiency anemia, and it becomes normal in almost 7 days. Serum ferritin check after 1 to 2 months, should be in within normal limits after 1 to 2 months. Continue iron therapy for 3 months after HB normalization to replenish iron stores. So that was all about initial anemia and then iron deficiency anemia.